Good morning everyone and welcome to week 4 of clinical contact session of this course on clinical management of HIV. So this week the topic was antiretroviral resistance, adverse effect and also the drug interactions. So there were two lectures. I hope all of you might have gone through these two lectures before attending these sessions. So the plan, like every time we do, is to review these two lectures and just to reiterate some of the areas which were touched upon by the UW faculty, and to uh, uh, again talk about what is the present scenario in India and also what NACO guideline says about all these topics. So again, as a reminder, I'd like to mention that participation in these clinical contact session is necessary. 70% participation is required for completion of the course. So there are total 10 sessions and this is the fourth one now. So if anyone has not attended previous sessions, so still there is an opportunity. From here on you can attend all the sessions. So please take care of that. And also about the weekly the assignments. So you need to complete the assignments after the clinical contact session is over, and also the homework assignments are to be completed. So this topic is very interesting in terms of it will allow us to discuss some of the areas which we routinely do not touch upon in our clinical practice at ART centers. This is the second lecture of antiretrovirals. In the first lecture, we discussed about basics of antiretrovirals and their properties, and then classes of drugs, and how they are used in first line, and all those things we have already discussed. So this session will specifically focus on the resistance basically, and also the second line, third line as far as NACO program is concerned, and how do we interpret the drug resistance reports. Those things we will discuss, which were already discussed in the UW faculty sessions. And towards the end, there will be a section of drug toxicities, which will be discussing in brief. So after this session, it is expected that all of you must complete the assignments and quizzes, which is requirement of this course. This slide we have discussed already earlier, that there are 6 basically classes of the antiretrovirals: NRTIs, NNRTIs, protease inhibitors, chemokine co-receptor inhibitors, and fusion inhibitor and integrase inhibitors. So the drugs which are highlighted in reds, as you very well know, that these are the drugs which are available in the national program. These are the first line drugs basically, or more commonly we use these drugs in first line, and also some of these we use in second line. PIs more commonly we use in second line, but at sometimes we use in first line also. In the last lecture we also talked about what is the first line and what is second line, how it is defined. Just to repeat that, first line is the drug or regimen which is initiated in a patient for the first time. That becomes first line for that particular patient. If that first line fails, then the subsequent regimen we start, or the complete regimen we change for this second time, and this regimen will become second line regimen for that particular patient. So it does not depend on which combination you are using in the first line or which combination you are waiting for in the second line. These two drugs like Raltegravir and Darunavir are now new, and they are available in the program for limited number of patients, and especially for third line, those who fail second line ART as per NACO. We use Raltegravir and Darunavir Ritonavir combination as a third line ART, which is available with the centers of excellence. We also talked about how these drugs they act. This is separate picture or different picture than what we had seen earlier, but it's the same one, or talking about the same things. This is nucleus of the CD4 cell. This is the CD4 cell as a whole, and this is CD4 receptor on the T lymphocyte, and CCR5 and co-receptor HIV virus getting attached to the CD4 receptor along with the co-receptors. It enters into the cytoplasm. single-stranded RNA gets converted into double-stranded DNA by reverse transcriptase enzyme, and then the integrase comes into action, which takes the proviral DNA inside the nucleus to integrate it to the human DNA. And when cell activation happens, the mRNA or messenger RNA will take the information into the cytoplasm, and the building blocks, that is proteins, are formed, which will be a longer protein, which will be cut down to the smaller proteins required for the new virion to be formed, and this action is done by the protease. So we spoke about the 3 enzymes and this one site. So there are drugs like CCR5 inhibitor or Maraviroc. It is called as chemokine co-receptor inhibitor, and here we have reverse transcriptase inhibitors. Our NRTI and NNRTI are reverse transcriptase inhibitors. We have integrase inhibitors, that is raltegravir we spoke about, which is being used in the 3rd line, and the protease inhibitors, which we commonly use in the 2nd line, and in some scenarios we use in the 1st line also. And one of the protease inhibitor, that is darunavir, we are using as a 3rd line. So this is in short the mechanism of action of antiretrovirus, which we have extensively discussed in the previous sessions. So let's talk about the ARV resistance. It depends on mainly 2 things. One is activity of regimens individual ARV drugs, and second is number of HIV-1 mutations required for development of resistance to each ARV. It can be easily understood with the fact that there will be some of the drugs which will become resistant even if there is presence of 1 mutation, and for some drugs to become completely resistant to the or virus to completely become resistant to that particular drug, you require accumulation of mutations. So it depends upon the potency of the drug which we are using in the combination, and also what is the barrier to resistance or genetic barrier to resistance for that drug. In the lecture taken by the UW faculty, one of the faculties, he gave very good example of a switch which we use to put on the light or to dim the light. So he gave example of the switch which can put on the light by only one action, or it can be like, or with one flash it can be like you can put it on or put it off. And then he gave another example of a dimmer. So there will be stages. So there will be some drugs which will act as one-time switch, that is if there is one mutation to that particular drug, the virus will become resistant. That drug will not then act. Or for drugs which are similar to dimmer, you require more than one mutations to be accumulated to become resistant. So those drugs which are which become resistant even if there is presence of one mutation are called as those who are having low genetic barrier to resistance, and those drugs who require more mutations to be accumulated are said to be having high genetic barrier to resistance. This will be further explained into the future slides. So what is basically resistance? See, HIV, it replicates very quickly. We talked about it in the very first sessions. So in a day there will be millions and billions of viruses or new virions will be produced, and when the virus does it at very rapid pace, so it will form mistakes, or it will make mistakes, or it will make errors. So the generations after one generation will not be exactly same as the previous generations were. So there will be slight difference in the structure of the virus, and when this happens, and with this happens repeatedly, then there is a chance that there will be a mutation, or there will be a new form of virus which will be developed. So viruses which are able to reproduce in presence of ARVs are said to be resistant to those drugs. So when we give antiretrovirals, what should happen is virus should not multiply. But because of these errors and because of this disrupted the sequence of amino acids in the viral genome, Now the newly developed strain is not active against the drug which you are using. So in presence of the drug, again the virus continues to multiply, and that virus will be called as resistant virus for that particular drug. Now what is the biological basis? High mutation rate and accumulating nearly one nucleotide mutation per replication cycle. We said that virus will replicate very fast. There will be a rapid replication of the viruses. So the rate or at which the mutations are developed, it is very high in HIV. So as long as the virus is multiplying, so it is making errors, and with each error there will be development of some amount of mutations or some mutations, and this rate of development of mutation is very high. So there will be quickly development of mutant viruses and accumulation of those. This is further complicated by high recombination rate whenever more than one viral variant infects the same cell. So we have CD4 cell. If suppose it is being infected by different kind of HIV viruses or having different mutations, then there will be again it will be further complicated, and also latent virus variants may periodically reactivate. Those latent viruses which are not multiplying all the time, so those variants may periodically may come again. Now this is regarding genetic barrier which I spoke about. So genetic barrier to resistance can be low and can be high, and this low genetic barrier to resistance, I gave and repeated the example given by the UW faculty, will be like a single switch on and off. So it one mutation, these drugs will be resistant, or virus will be resistant to these drugs. If these are the drugs, if genetic barrier increases, which means that these are the drugs which will require more than one mutations to be accumulated for the virus to become completely resistant to these drugs. So these drugs are considered to be having high genetic barrier. If you see here, Nevirapine, Emtricitabine or Lamivudine, these are having very low genetic barriers. So like one single switch, while all these are like dimmers. So you need accumulation of mutations to for the virus to become completely resistant to these drugs. Like Zidodin, Savodin, Tenofovir, Didanosine, Abacavir, Altigravir, Raltegravir. So all these drugs have now in the middle range as compared to these like Darunavir, Lopinavir, Ritonavir. That is why you are seeing that Darunavir now in our program is being given as a third line because it is having a very high genetic barrier. You can add one more drug to it, that is Dolutegravir, which is a integrase inhibitor, which also has a very high genetic barrier. We'll talk about that in subsequent slides. I hope I'm clear up till now. If there are any, because I understand that this is a topic which we are not dealing with on day-to-day basis. So if there are any questions, you can pose your questions. If this speed is, you are thinking that it is fast, you can let me know. I can further go slow on this. Or if you feel that this is very slow, I can go faster also. So about types of resistance, there can be induced or acquired resistance. Induced resistance is the high rate of HIV replication plus high mutation rate result in a complex and diverse mixture of viral drug susceptible virus and drug resistant virus. There are two things which are said here: high rate of HIV replication and high mutation rate. We spoke about both these things. So this is cause of induced or acquired resistance within a person's body. So there can be two types basically: transmitted resistance and acquired resistance. As name suggests, acquired resistance means resistance develops in a person's body. So this may make the virus less susceptible to ARVs, antiretrovirals, and this is dependent upon many factors. This is most commonly what we see in our ART center is acquired resistance, we can say. We can assume that there is no data to back this up, but factors for that is level of drug, for example, at the site of HIV replication. If there is poor adherence, suppose a person is not taking ART regularly, So the level of HIV virus will not be constant in a person's body, and whenever there is low level of the drug, it will allow the HIV virus to multiply. And suppose a person is using single drug or two drug therapy in place of multi-drug combination or three drug combination. So this also will cause the development of acquired resistance. So this is one type of resistance. Now primary resistance, patients infected with drug resistant HIV strain. For example, a person is having suppose drug resistant strain, and because of or from that person HIV is transmitted to the other person. So the other person who is receiving HIV virus now will be having all those mutations in him. So that person will also be having these resistant strains and will be resistant to these particular drugs. Now, why does resistance develop in a treatment naive individual? Treatment naive is those people who have not taken ARV before or new patients. So, inadequate ARV levels in the blood. We talked about that. Why this happens? One problem was non-adherence, that a person is not taking ART regularly. And there can be others also. There can be drug interactions. There can be drug food interactions. For example, if I talk about the proton pump inhibitors, they interact with the PIs. So if you are using PIs, you should be careful by using proton pump inhibitors. We separate out the timings. We don't increase the doses. So all these are example. For example, if I talk about the drug food interactions, the common drug which we use is efavirenz. And if it is given with fatty meal, then the toxicity of efavirenz will be more, and people will be having and also it may reduce the concentration of the drug. So which causes again inadequate ARV level in the blood and gives the opportunity for the virus to multiply in presence of drugs also. Then inadequate potency of a regimen or individual drug, for example, using 2 or 3 drug combinations, 2 or 1 drug. Now, how it can be recognized? Now, as the best way is to detect the mutations. As we spoke about, if you want to see that a particular virus is resistant to these many drugs, the best way for that is doing genotypic or resistance testing, which is not available in the program, but it is available in the market. So, but what other indirect indicators are which can tell us about failure to therapy is the clinical criteria, immunological criteria, and virological criteria. This we follow in the NACO program. Then that if a person develops stage 3 or stage 4 opportunistic infection, he is said to be having clinical failure while on ART. And if a person is suppose having, there are 3 criteria which are included under immunological criteria. We'll talk about that. And virological failure is if on ART, if the viral load is still more than 1000 after a minimum of 6 months of antiretroviral treatment, then it is said to be having virological failure. So how it can be detected is we are doing viral load. If viral load in presence of ART is more, we are doing the change of regimen from first line to second line. But the ideal way to detect the resistance, there is a difference between resistance and failure now. Drug resistance is we are identifying mutations. We are saying that because of this mutation, this virus is resistant to this drug. That is about the resistance. So, but if there is failure of regimen, that is one regimen, it is failure to that, we are moving to the second line regimen. I also spoke about in the last session regarding the individualized treatment approach and program approach. What we follow in the national program is a program approach. So we have a defined preferred first line ART regimen. If a person fails to that, which we identify by doing viral load, if a person is not doing well in terms of like CD4 is not increasing, we follow immunological criteria of failure. If person satisfies those criteria, we go to the viral load testing. And if viral load is more, suppose we switch the regimen from first line to second line. But there is another way of treating patients, that is individualized approach, that you start your combination, 3 drug combination to the patient, And if there is regular viral load monitoring or routine viral load monitoring, then you will be seeing the response to therapy. And if suppose the response is not good, then before shifting to the second regimen, you would like to do the drug resistance testing. In fact, if you see the Western world, they do the drug resistance testing before initiation of first line. Before putting the patient on ART, they do the resistance testing. We don't have that luxury with us because of, again, availability of facilities. So we don't do it, but that is being followed in the Western world. So there are two types of resistance testing. If we talk about resistance testing, there are two types. One is phenotype, second one is genotype. I'll go again slow on this. Don't get confused. It looks complicated, but it is not. So phenotype is basically, it will measure the ability of virus to grow in presence of various concentration of ARVs. So it is very expensive and it takes time. So you require at least more than 1000 copies per ml of the virus to do this kind of testing. And the results they are summarized in terms of the concentration that inhibits viral replication. So what is IC50? It is inhibitory concentration 50%. So it is compared with the actual time and with the sample time. So results are reproduced as levels of fold of resistance, which are calculated by dividing the inhibitory concentration of the investigated virus by the control virus. So basically, phenotypic resistance testing is not used these days, or except in very rare situations, but otherwise it is not used at all, because it will not be useful in determining the next line of therapy. It will just tell us that what is the minimum concentration of drug which is required for bringing down the viral load to the 50%, or minimum inhibitory concentration of IC50, that is called. So it can only be used if suppose a person is having very much experience with ART, almost have used all the drugs, then it can be used, but I'll not go in details of that. Please remember that it is expensive and it is not being used, phenotypic resistance testing. The second one, in comparison to that is genotypic testing, is something which is very helpful. Now we spoke about the resistance strains or the mutations. So these mutations, if you want to see them, you need to do these genotypic testing. So as a result of genotypic testing, the lab will give you the exact mutations what have happened in that virus. I'll again come back to what mutations are and how they look like, or how they are reported in the future slides. But this is comparatively less expensive, but again it is a very specialized investigation which is not available everywhere, but it is available in the market. It may take 1 or 2 weeks, and it also with the help of softwares, there are databases. With the help of that, if you enter these mutations into those databases, it will give reports with explanation of the future options, which are the future options and which are the current options. All those things are given. Now let's try to understand how these reporting is and what these mutations are. Now you know that HIV virus is an RNA virus. It has a genome, RNA genome, which will ultimately have list of amino acids. So there is a term which is very commonly used, that is wild type of virus. Wild type, that means it is the original virus which is supposed to be having a particular amino acid sequence. So any virus which is under test, or any sample which is under test, that sample is compared with that wild strain just to see whether the amino acid sequence in the test sample is same as the wild type sequence or not. So this is it is reported like this: M184V. For example, this is one mutation which is being reported, where 184 stands for the number, the position of the amino acid in the whole sequence, and M is the original amino acid which was supposed to be there in that position, and V is the amino acid with which this amino acid has been replaced. So by error of multiplication, we mean that in the amino acid sequence, which a wild type of virus is supposed to be having, there will be some change. There will be replacement of one particular amino acid with the other one. So if you can imagine that sequence at 184th position, methionine is replaced by valine. So that is that mutation is reported as 184V. Abhishek Agarwal says sound is not clear. Sound is clear for the others? Okay. Abhishek, you can please check your internet connection. So, what is the cost of genotypic testing in India? I am not sure exactly, but it might cost more than 10,000 for one test. I'm not very sure, but again, it depends on the lab where you are doing, and also there are some labs which are very good. I'll not mention those labs, but it is available. You can inquire in the market. It is available, and rates you can directly. And most of the times we negotiate rates with lab also. So it is something like this. That is M184th position. M is being replaced by methionine or by valine. So this is just for the information list of amino acids. If you have forgotten the names of amino acids, this is the list. It is not necessary to remember all this. This is just as a reference you can use. So what happens if you send the blood, the sample for resistant or genotypic testing? Lab does that testing for you, and they will find out mutations like M184V. I gave an example of that. So what you should do after all that, now there are specific mutations which are seen for specific class of the drug. There are particular mutations which are seen under NNRTI, under NRTI, under PIs, under integrase inhibitor. There are specific mutations which are seen. Now you have those mutations, suppose, with you. There are many databases actually which will help you in interpreting all these mutations report. This is one of the example, that is stanford.edu. If you can see here, hivdb.stanford.edu. It is an open free site where you can open and practice. If you have mutations, just put it. It will give the interpretation. I'll show you how that interpretation is done and how we'll come to that. You can practice it in your center also. You can just put some mutations which you know of and just see what interpretation it gives and read it out. So here you can focus. There is a sign here, HIVDB program, genotype, resistance testing. So you can click on this. It will show you this page. Analysis, mutation list, analysis, sequences. You need to click on analysis mutation list. It will take you to this page. Now, like I said, the reverse transcriptase, protease, integrase, these are classes of drugs, right? So whatever mutation list which has come from the genotypic testing, for example, suppose for reverse transcriptase, now it includes both NRTI and NNRTI. If I talk about 103, okay, now focus on this. So if I click on this, it will give you options of multiple amino acids. Now there is a very common mutation for NNRTIs, especially nevirapine. It is K103N. That is, in place of K at 103 position of the amino acid sequence, it has been replaced by amino acid N. So if you select this N, it will go here and then you click on analyze. Can you see here the analyze button? So you put whatever mutations you have. For example, M184V we saw, that is for reverse transcriptase. Again, if you can find it out here, there is 184th position here. So 184th position, you need to click it here, and you can see we have already put is 184V. So Actually, in this position, there should be methionine, but in your amino acid or resistance testing or genotyping report, you have received that now the new mutation is M184V. So you have selected V here. So now you have selected one mutation for at 184th position, another mutation at 103 position. Now you want to know what does it mean in your clinical practice, what all these numbers mean. You click on analyze, it will give you a report like this. Now if you read this, the upper part, so it will give like NRTI resistance mutations K65R. Did we click on 65th position also? Yes, this I again missed. 65th position, K has been replaced by R. So we have entered 3 mutations in this list. One is at 65th position, 103rd position, and also 184th position, right? So and then you have clicked the analyze button here, and it has given you interpretation. Now NRTI resistance mutations K65R, K70E, and M184V. NNRTI resistance K103N. So it will give you this: Lamivudine high level resistance, Abacavir high level resistance, Zidovudine susceptible, Stavudine high level resistance, Didanosine, Emtricitabine, Tenofovir all have high level resistance. But does it stop here? Answer is no. So if suppose I give an example that Lamivudine has high level resistance, and this was our patient who is on suppose initial first line, then why are we using Lamivudine in the second line treatment? This is the question which should come in our minds. So if you read this out, K65R, you remember now few mutations I'll tell you which you can remember which are very specific to particular drugs. So like K65R is specific for Tenofovir. Okay. K103N is specific for Nevirapine. M184V is specific for Lamivudine. So at least these three you remember for now, then we can go ahead. K65R causes intermediate or high level resistance to Tenofovir. I'll stop here and I'll just tell you that in other diseases, for example TB, if you see high level resistance, the drug is out. You are no more using this drug. But what is the benefit sometimes in HIV? Even if suppose you have a particular mutation, that can be beneficial for the other drugs to be used. That can be a scenario. K65R causes intermediate or high level resistance to Tenofovir, DDI, Abacavir, D40, 2 to 3 folds reduced susceptibility. That means it reduces its susceptibility, and to low or intermediate resistance to 3TC or FTC, that is Lamivudine or Emtricitabine. But read this: K65R increases susceptibility to Zidovudine. What does it mean? That if you are using Tenofovir in the first line, and because of the mutations or resistance, a person developed this mutation, that is K65R. Now, if you want to change that first line to second line, now in the second line, what are the drugs you are using is, if you have used Tenofovir in the first line, in the second line you use Zidovudine. Why you are using Zidovudine is for this reason. That is, the person was on K65R and now is in having virological failure. We are assuming that person might be having K65R in his or her body, and if we start this patient on Zidovudine, then it will be very beneficial for that patient, because K65R is increasing susceptibility to Zidovudine. Similarly, if you see another example, M184V or I causes high level resistance to 3TC and FTC. Okay, agreed. Now, the Lamivudine and Emtricitabine will be having high level resistance if you have M184V mutation, and low level resistance to some other drug like Abacavir also. However, M184V are not contraindications to be continued in the treatment with 3TC FTC, because they increase susceptibility to Zidovudine, Tenofovir and D40. Now you can relate this to our first line and second line. In the first line, in NACO program, we are using Lamivudine, right? In the second line, again we are using Lamivudine. So please don't think that we are using some drug which is already resistant in the first line. Suppose first line combination was Tenofovir, Lamivudine, Efavirenz. Person develops first line failure. You change the regimen, you switch the regimen to second line. In the second line, you give Zidovudine, Lamivudine, Atazanavir, Ritonavir. One can think that the NRTIs were used in the first line and Lamivudine was the very drug which was already used. Now in the second line we are again using Lamivudine to which a person has failed, and Tenofovir we are replacing with Zidovudine, which is again a NRTI. So the only new drug we are introducing is PIs. To some extent though it is correct, but there is strong justification that we can or we have to use these drugs in the second line. So this is one of the justification that if a person is having K65R mutation, it increases susceptibility to Zidovudine. Similarly, if you have M184V mutation, this increases susceptibility to not only Zidovudine but also to Zidovudine, Tenofovir and Stavudine. There is one more point here which you can see, that if a person is having M184V, which almost every person who is failing the first line will be having low level resistance to Abacavir also. So those who think that why can't we use Abacavir in place of Zidovudine in second line, answer lies here. Because Abacavir is not supposed to be very sensitive in the second line if first line has already failed. Because if a person is having 184V mutation, then there will be a low level resistance to Abacavir as well. Similarly, K103N, as I mentioned before, it will be having high level resistance to Nevirapine, that is 50-fold reduced susceptibility, and also to Efavirenz, but as compared to Nevirapine, it is better, that is 20-fold reduced susceptibility. So this is regarding how these mutations are interpreted by using a database. So what these labs, these current labs who does this genotypic resistance testing, they again make your job easier by doing all this for you. They'll identify the mutations, they'll put the mutations in the database, and they in the report, if you see genotypic resistance testing report, you will have all these comments also. So you need not again go to the database and use it. But what I'll recommend is, with these mutations, click on this website and try to practice use of this database and try to read the comments. We cannot stop here. That is the whole point. We cannot stop here by just seeing that there is high level resistance to some drug. So this is how an individualized approach is used, where we exactly know what is the resistance and which drug will be effective. But if you see the program approach which we are using, it is not very different with that, with what we are doing. Only in cases which are exposed to multiple drugs and multiple NRTIs, and they may be, suppose, exhausted all the drugs which are available, in those situations, in those reserved situations, we might need this because we have limited options with us. So in this scenario, the program approach is best for a country like us, where we are treating almost 2 million people for ART. More than 1 million are already on treatment. So this is how it is being used. So I'll recommend that you practice it once or twice so that you become comfortable with this, and you will be able to understand more and more things regarding usage of the ART medications. What about the cross resistance? So thankfully there is no cross resistance between classes. That is, if a virus is resistant suppose to the NRTI, they are sensitive to the other class of resistance. There is no class resistance. In fact, there is in vitro synergism between classes of drugs like NRTI and NNRTI. If both of them are used together, there will be synergism. Then high level of cross resistance within each class of drug. This is actually problematic. If suppose you have, for example, K103N, there will be a resistance to nevirapine, including to that there will be a resistance to efavirenz also. There is a question here: if the patient on TLE is changed to TL atazanavir ritonavir for tenofovir resistance, then patient develops resistance to lamivudine, then what is the treatment given? I'll come to this. This question will be answered in future slides, but I'll just comment one thing here. In presence of lamivudine resistance, susceptibility to the next line of treatment, we already saw that if you have lamivudine resistance, and even if you are using suppose tenofovir in the second line, then also the susceptibility to tenofovir will increase. So in that context, it is okay to use. But if you have a new drug available to which a person was not exposed to, then you should use zidovudine and not tenofovir. But I think this answer will be more clear as we go along this presentation. Okay. So in patients developing virological failure on first line ART, extent of drug resistance is roughly proportional to the duration of uncontrolled viral replication in the face of selected drug pressure. What does it mean? What does it mean for us? See, if you are having a patient who is on first line ART doing well, you continue with the treatment. But if suppose there is a problem with adherence and there is development of first line ART failure, and there is resistance which has developed. Now, if you continue the patient, as soon as you identify, if a person is suppose, then you improved upon adherence and patient improved adherence, and now patient is adherent to treatment for at least 6 months, but then still you are seeing the decline in CD4. Now, if you find it out that there is immunological failure, that we should not waste time in referring patients for second line ART in these scenarios, because if you allow a patient to continue on a failing regimen, that will result in more and more mutations are to be developed, and there will be accumulation of mutations, and which will compromise the second line treatment also. So this is takeaway from this slide, that if you find out that there is an immunological failure, we should not waste time in or we should not continue the same patient on the first line on the same failing regimen for long time. Even though we say that until unless second line is initiated, first line is not stopped, that is for another reason. But there should not be a delay from identification of a failure to switching on to the second line treatment. Now this has beautifully been explained by the UW faculty in the lecture, if you see. And this is the emergence of wild type HIV after stopping antiretroviral therapy. I told you what wild type means. Wild type virus is the suppose original clone, that is original virus, and which has a defined sequence, defined amino acid sequence that is labeled in brown. And these colorful ones are resistant viruses. So before treatment, there can be some level of mutations already present in a person's body, because we said that virus multiplies rapidly, millions and billions of the times in a day, and it makes error. So because of that error, there can be some resistant strains, but this will be for to a small extent. As soon as you put a person on ART, immediately the person's viral load will go down. You have blocked multiplication of the viruses. Most of these wild type of viruses will disappear, and in fact there will be some resistant virus also will disappear. So that also happens, but some will remain. So this is the controlled viral load or viral load below detectable, for example. Now what happened is there are adherence problems. Patient is not taking ART properly. So you are still giving ART. Because of your ART, what has happened is wild type of virus is under control, because this is responsive virus. This virus is responding to the treatment which you are giving. But the other viruses which are resistant, their number is increasing here. So more the adherence problem, more resistance strain will go on increasing. So there is a point here which I would like to make, that if you want to do resistant testing, you should not stop the treatment what you are giving and then send the investigation for resistance genotyping. That you should not do. If you do, what will happen? This will happen. If a person stops ART here, the wild strain goes up, because wild strain is a stronger strain as compared to the resistant strain. So if a person goes off ART, wild strain number will go high and resistant number will go down. And if suppose here you send the sample for genotypic testing, you will see wild type of virus. You will not see this resistant type of virus is there. And it will be misleading report, and you will ultimately land up in saying that patient does not have any mutation and this ART should work. And in the same way, what will happen is, suppose a person is non-adherent to treatment and reports back to you after, say, suppose 1 year, after being on ART for 2 years or 3 years, where viral load was good, and then patient started becoming non-adherent, and ultimately patient stopped taking treatment. And after some time, patient came back to you, you put the patient on ART. Then you will see that there will be a good response initially. If you monitor this patient virologically, even immunologically, you will see that there is a drop in viral load, there is increase in CD4 count. Why it happens is because of this. Because once a patient is off ART, wild type of virus will grow. You give the same ART which the patient was on, there will be a reduction in viral load, which will definitely happen. But this will happen in initial 6 months. After that, what happens is your wild type of virus is under control, and then your resistant type of virus will grow, and ultimately patient will end up in failure. And if this happens, there are more and more resistant mutations which are getting accumulated one after the another, making your further line of treatment more difficult, and is a compromised second line. Now let's go to specific mutations, which were, and now from here on there will be quite a few slides from the UW faculty which are beautifully explained there. I'll just repeat them. Few points I'll repeat. So for zidovudine and stavudine are called as thymidine analogs. Now you need to remember this term, thymidine analogs, because the mutations related to these are called as thymidine analog mutations. You need not remember these list of mutations, but remember this term, thymidine analog mutations, or in short they are called as TAMS, T-A-M-S. So TAMS are the mutations for these thymidine analogs, that is zidovudine and stavudine. So for we spoke about genetic barrier to resistance. So these drugs are like dimmers, and they are in the middle of the graph which I showed you from on the scale of 1 to 4. If 1 is the drug which is having very low genetic barrier to resistance, 4 is drug having high genetic barrier to resistance, these drugs are in middle. What does it mean? If virus develops this mutation, this drug will still be active. You can still continue using these drugs. But if you continue the patient on a failing regimen, slowly there will be accumulation of mutations. There will be more and more mutations will be accumulated, leading to complete high level resistance to zidovudine and stavudine. This is called as accumulation of TAMS, thymidine analog mutations. They may follow a particular pathway, that is, after one mutation, which will be the next one, which will be the next one. There are two pathways for TAMS. This is type 1 TAM pattern and type 2 TAM pattern. If they follow type 1 pattern, that is first this mutation, then this, and then this, there will be high level zidovudine resistance, higher level NRTI cross resistance, and less decrease in resistance with M184V. That is, even if you use M184V, it may not be useful. Even if you use lamivudine in the second line, it may not be useful in comparison with this. If a virus takes this pattern, that is type 2 TAM pattern, and there is accumulation of these mutations, there will be lower level resistance to zidovudine. That means they can be still used, lower level of NRTI cross resistance, and more decrease in resistance with M184V. That is, this is type 2 TAM pattern is better to be had than type 1 TAM pattern. So in this way, if you know mutations, you can see that what are the mutations and what is the sequence in your report, and then you can decide upon that whether using Lamivudine in the second line will be good, or what can you expect from Lamivudine. Do you expect some better results, or there is it is decreased resistance with M184V. So these are multiple patterns. Now this again, if you see here, TAMS along with Lamivudine. Now we spoke about these two separately. Now let's talk about the combination. You're using Zidovudine Lamivudine or Stavudine Lamivudine. First mutation to appear is M184V. So in all mutations, if you see, the quickly developed, or the image is not seen. This is from the presentation which is being done by the university. So you can download the PDF from the university website, that is Canvas also. It is there on the Canvas. So the first mutations to be developed or to develop is M184V. So in a patient, if you see, if you start ART, if they miss some doses, and this is what they refer to as a single switch. That is, in one shot from light to it will be dark. There is no dimming phenomenon here. So M184V is first to appear, and then it may follow the these patterns. So if you see here, you can be sure that patient already has M184V in him or her. Similarly, I told you to remember one mutation for a particular drug, that is for Tenofovir. Please remember K65R. So for this pattern, for this combination, that is Tenofovir Emtricitabine combination, patient will first develop M184V, that is for Emtricitabine, which is very similar to Lamivudine. We have discussed this before, and then patient will have K65R, which is specific for Tenofovir. Similarly, Abacavir Lamivudine 184V, K65R, L74V. Here we also said that if a person is having K65R, will be having resistance to Tenofovir, and also will be having low level resistance to Abacavir. Just a summary of that: Zidovudine Lamivudine, first mutation to appear will be M184V, then it will be further TAMS, either following type 1 or type 2 TAM pathways. Similarly is with Stavudine Lamivudine combination. Tenofovir Emtricitabine, first will be M184V, then it will be K65R. Abacavir Lamivudine combination, first will be M184V, then it will be L74V or K65R. Now we spoke about the wild virus, and if you put your all NRTIs here on this scale of high level resistance to increase susceptibility. See, here is the 0, for example, where drugs are sensitive. So on the right side, if you see, there can be increased susceptibility. On the left side, there is a resistance, low level resistance, high level resistance. All these drugs are now susceptible in wild type of virus. We said that wild type of virus is the original virus where you have a as expected, the expected amino acid sequence. Now all these drugs are susceptible. Now what we will do is, we will just see that with particular mutations, how this scenario changes. Changes in terms of development of resistance. That whether in presence of those mutations, the drug becomes susceptible or more susceptible, or become resistant to the drugs. Image is not seen to everyone. Can you please check, Praveen? I see. Okay. Oh, if some of you are able to see the image, then I think problem is not from my end. Please check your connections. Thank you. So let's see this now. By this time, I think you will remember that 184V is for what? 184V is for Lamivudine, we said, and it is for exactly the other drug, which is Emtricitabine, which is very similar to Lamivudine. Now this M184V, if a person is having, you can see here that is Lamivudine and Emtricitabine will be having high level, or virus will be having high level resistance to Lamivudine and Emtricitabine. But if you see here, and also we said that it may cause a low level resistance to Abacavir also. You can see here from the susceptible point, Abacavir has moved to the left. Ridanosine has moved to the left, though we are not using ridanosine these days. But Abacavir, we are having low level resistance in presence of 184V. What is the advantage? Advantage is this. Tenofovir, Zidovudine and Stavudine also have shifted to the right. That means their susceptibility is increasing in presence of M184V or I mutations. Okay. So I hope you are with me on this. This is now again I'm trying to explain with very basics. So you can just see with this picture that how the development of mutation, it will affect the susceptibility of drugs. Now let's combine M184V with multiple TAMS. Now this is very common situation where which we can imagine at ART center in a person who is failing first line ART since long time and is not being initiated on second line ART. So in those patients, what will happen is all the drugs have moved to the resistance side. The person, your usage of Lamivudine in second line will no more help as it should help in the previous scenario. If we see, if you are able to diagnose first line ART failure early and are able to put on the patient on second line ART soon, then the Lamivudine help will come. That means in presence of 184V, there will be increased susceptibility to Tenofovir, which we saw here. So this will happen only if M184V is, or the switch from first line to second line happens early. But if you allow TAMS to be accumulated in more and more in numbers, then what it will cause is this. It will reduce, or it will make every drug high level in the category of high level resistance. Okay, so this is M184V along with multiple TAMS. Now let's see K65R. I told you K65R is specific for which drug? You can type your answer. TDF, exactly. So this is specific for Tenofovir. So if in presence of K65R, you will be having or patient will be having high level resistance to Tenofovir. Along with that, there will be resistance to the other drugs, like you can see here. But you can still use Zidovudine in those patients as a second line because it has increased susceptibility of Zidovudine. You can see here, this is the susceptible point and it is shifting to the right side. That means presence of K65R causes resistance to Tenofovir, but it will increase susceptibility of virus to Zidovudine. That is the reason if a person is failing, a person who is on Tenofovir in the first line, if fails, we say that I think this is the answer for the question which was asked some time back. That is Zidovudine we used in the second line in place of Tenofovir. Now combine these two, M184V and K65R. Now in presence of this, as both of these M184V and K65R, both of them we saw that they increase susceptibility to Zidovudine. So in presence of these two, though all the other drugs are resistant, Zidovudine sensitivity will further increase, susceptibility will further increase, because both these drugs like M184V and K65R, they increase susceptibility to Zidovudine. So this is just a summary. This is regarding NNRTI. I told you to remember this K103N for nevirapine. So K103N, most common mutation with efavirenz failure and also with nevirapine. In fact, nevirapine is more than efavirenz. K103N does not significantly impact rilpivirine and itravirine. So those are not commonly used, or in our program these are not being used. So these are the other mutation combination. Most commonly mutation in rilpivirine. Again, we are not using this. E138K has low level impact on etravirine and efavirenz, and etravirine has high level barrier and complex resistant patterns. So rilpivirine is a drug which is used in other parts of the world also, and but not used commonly in India. For this slide you can remember K103N, which is again, it is like very low genetic barrier to resistance. Quickly, if a patient misses suppose few doses, a person can develop resistance, or virus can develop resistance, and mutation of K103N. So this is for NNRTI. These are the NNRTIs listed here for wild type of the virus. This is the susceptible one. Left side resistance, right side susceptibility, increased susceptibility. So if you have K103N on NNRTI, efavirenz and nevirapine will be out, but still there will be sensitivity to etravirine and rilpivirine. These are not affected by K103N, which is basically mutation for these two drugs. But in presence of E138K, all the drugs or all NNRTIs will be out, and all will have low to moderate or intermediate resistance. Now there are other mutations like Y181V, which is supposed to be again a bad mutation to have, because it doesn't have any benefits. It will have resistance to all, high level resistance in fact to all NNRTIs including rilpivirine. Now this is just a study which I copied from the UW faculty lecture, which compares darunavir 800 mg OD to darunavir 600 mg BD. So where people have concluded that even if you use OD, the response in terms of viral load suppression is same. In our program we use darunavir as a BD combination, which will come back later. Now raltegravir, again, it like NRTIs, like TAMS, we saw it follows multiple pathways like mutation, primary mutations and secondary mutations. There can be so many. There are 3 integrase inhibitors, and third one is dolutegravir, which is these days is very famous in especially in US and other countries. We have raltegravir in third line therapy in NACO program. But the point I want to make here is, if a person develops some mutation to raltegravir, it is advisable to change that drug as soon as we can to dolutegravir or the next line of treatment. Because if you continue a patient on failing regimen, again I am repeating the same thing, that if you continue patient on same regimen, suppose you are using raltegravir and a person develops this, and then it is continued because it goes in this pathway, and more mutations are developed suppose in this particular patient, then what will happen is, even if suppose in future you give dolutegravir in this patient, that will not be effective. So it will have within class cross resistance if there is accumulation of mutations. Similarly, elvitegravir has specific pathways which it follows, and it may cause accumulation of mutations. So raltegravir, moderate genetic barrier, that means it is like in the middle somewhere. Then 3 distinct common pathways, you need not remember them. Continued use with failure causes accumulation of integrase mutations, and it causes, if this accumulation happens, dolutegravir also will become mutant. That is high genetic barrier. Otherwise it has very high genetic barrier to resistance, active against single mutation variants, and activity is reduced with certain combination of integrase mutations. So if you allow this to continue, if a patient is failing on suppose raltegravir, and if you allow that to continue, ultimately what will happen is dolutegravir also will be resistant in those patients. Okay, so now let's switch to the NACO guidelines. Where are we in this scenario, in all this? So we try to cover up the resistance, how it happens, which are the tests which are available, how to interpret the mutations, how to read the mutations first, then how to interpret mutations, how to use the databases, and how to decide the next line of treatment. This is all good if you have ideal situations where you have accessibility to each and every drug and also each and every test. But unfortunately, we don't have that luxury. So we work in program situation which balances most of these factors, especially in new patients. So it doesn't matter if you do resistance testing or not, in especially in new patient, if you are working within the program, because we have specific regimen for those patients. And now you can imagine how these particular regimens have been designed. So one can think that why Lamivudine in second line, why only this PI in second line, why are we not using in the first line? That all the explanation is what we had discussed up till now. That is, certain drugs will have low genetic barrier to resistance, certain drugs will have high genetic barrier to resistance. Those drugs which are having very high genetic barrier to resistance are used in second or third line of treatment. Those drugs which are having intermediate genetic barrier to resistance are used in the first line. And also the cost and everything will be dependent on these factors. So from here on, I'll be I'll go through very fast because most of you are aware about the NACO guidelines, but it is my duty to take you through this because ultimately this is what we are going to practice in our centers. So treatment failure, it is defined as the loss of antiviral efficacy and triggers the switch, that is, it tells us that now there is a requirement to change from first line to the complete change of the new regimen to the new regimen, that is second line. Switch to the entire regimen from first line to the second line. It is identified by clinical, immunological or virological monitoring. Second line, as I am repeating it again and again, is the next regimen which is used in sequence after the first line therapy has failed. So we saw this before, that is, in selecting first line, what we are doing, we are taking 2 NRTIs, 1 NNRTI for the first line, and failure of first line ART is generally defined through all these 3 types. So there are 3 types of monitoring which we are doing. One is clinical monitoring, that is through body weight, clinical staging, that is OI we are looking at. Laboratory monitoring, that is routine lab monitoring as per guidelines, appropriate blood chemistry, blood counts, or including hemoglobin and CD4, etc. And adherence also we are seeing. Now we can talk about 2 things here, which is actually very soon we will be talking more about it. That in laboratory monitoring we are doing CD4. Now we said that in previous session on ART that virological failure is first to happen, which is followed by immunological failure, and last to happen is the clinical failure. So by the time patient has clinical failure, the virological failure had happened long back. So if you have routine viral load monitoring in your program, that means viral load test available for each and every patient of ours routinely, that every year or whatever frequency you can decide upon. Like our CD4, right now we have CD4, though there is a problem of kits and other things, but still CD4 we have every 6 months patient need to undergo CD4, which is available to them. Now if you compare viral load and CD4 testing, which one is better? So in ideal situations, as we have spoken before, viral load will obviously give a better understanding about patient's failure because it also will indicate the treatment failure early in patient's treatment. Because we saw that immunological failure is late to happen and virological failure is first to happen. Okay, so for monitoring purpose, if you see the better test, if you ask someone, then it will be a viral load as compared to the CD4 testing. But the issue is we do not have availability of routine viral load testing. We still have targeted viral load testing. NACO will very soon announce the routine viral load testing. They are in a phase of scale up of viral load facilities to the count of maybe 80 or so. So as very soon it will be available for all our patients routinely. Then this decision will be taken whether CD4 monitoring will be continued as we are doing now or there will be some change. So with recommendations like even WHO, they say CD4 can stop being tested in situations where viral load monitoring is routinely available. Now again we can argue a lot on this, because then how will you initiate the OI treatment, how will OI prophylaxis, and when will you stop OI prophylaxis if you don't have CD4 count? All those things are absolutely correct. But ultimately if you compare viral load and CD4 testing for monitoring a patient on ART, viral load is a better test for monitoring than CD4 testing. Of course CD4 has some advantages which we can discuss when this policy is announced. But as of now, we are continuing with the CD4 testing and targeted viral load testing. Now, treatment failure, this is what I was talking about. Clinical failure is last to happen, virological failure is first to happen, and then which is followed by immunological and then clinical. These are criteria for labeling someone as a clinical failure. If a patient is on ART and develops stage 4 condition after at least 6 months of ART, then we call that person as having clinical failure. For immunological failure, fall of CD4 count to pre-therapy baseline, that is from where you started, patient has dropped the CD4 count to the pre-therapy baseline, that is immunological failure. 50% fall from on-treatment peak value, that is you have started treatment, CD4 goes up and up. It has, suppose from 200 it has gone up to 600, and now it has again fallen down to 250 suppose. So this is more than 50% fall from on treatment peak value. Then persistent CD4 level below 100. That means you are treating patient for suppose 6 months or 1 year, still the CD4 is below 100. Then any of these conditions, if is seen, is labeled as immunological failure. And as per present guidelines, if you see any of this, you should send patient to SASF for viral load testing and further initiation of second line ART. When they do viral load testing, when they label the person as first line ART failure or second line ART failure is if suppose patient's adherence is good, and if ART has been given for minimum period of 6 months to 1 year, and even then if suppose viral load is more than 1000 after at least 6 months of ART, then it is called as virological failure and patient becomes eligible for next line of treatment. We have seen this that whenever a patient is on ART, there should be high level of suspicion. That means you should see for OIs, new OIs, and then clinical deterioration in spite of good adherence, then progressive CD4 decline or slow or no clinical improvement. All those things should be recorded. Co-infections are important. Co-infection with Hep B, Hep C. Then if there is evidence of iris, then if there is any certain WHO stage 3 conditions, for example TB, that should also be considered as clinical failure. So what ART center does is they will monitor all these patients who are on first line ART and then also on second line ART, and they'll see if there is clinical deterioration or immunological failure which is happening. If there is any evidence of immunological failure, then an email is sent to SASEP in definite formats. So if there is immunological failure, that is suspicion of failure by following these criteria, or if there is clinical failure, then you refer patients to SASEP. But before referring patients to SASEP, you check few things. First of all is you should see whether patient is on ART for at least 6 months or not. Then you should see whether patient's adherence is good, that it should be at least more than 95%. Even if it is 90%, then you should consider that referral. This for ART plus and SASEP. Don't again stick to only 95%, but even if suppose at one time patient is having 90%, don't send patients back. Adherence should be good if a person is on ART before labeling a patient as immunological failure. Most recent CD4 should be done within 1 month before referring, we should see, and we should also see whether CD4 indicating treatment failure or not. That is immunological failure criteria, 3 criteria we spoke about, those are being satisfied or not. Then SASEP advises viral load, and based on these counts, they will take further actions. If the viral load is more than 1000 in a patient who is good or adherent to ART and a patient who is having regular ART, and in those patients, if and patient is on ART for at least 6 months to 1 year, and if in those patients viral load is more than 1000, that is confirmed as failure, and patient is eligible for initiation of second line ART. If viral load is less than 400, then patient is asked to continue on the same first line, but will be asked to do CD4 testing every 3 monthly, and viral load will be repeated after 6 months. If it is between 400 to 1000, then same first line ART will be continued at the referring ART center, and viral load and CD4 will be repeated after 3 months. SASEP mechanism has been revised. You all know what SASEP mechanism is. I will not go in details. I will just mention one thing, that in SASEP you need to ensure that once you identify the patient as immunological failure, you send communication to the COE or ART plus. They'll give you they'll let the patient know regarding 2 appointment dates, of which one is to be confirmed to SASEP by feedback mechanism, and then a patient is invited on that particular day to SASEP. When patient goes back on that particular day to SASEP, it should be ensured that patient goes along with all records, necessary referral form, and also along with that, patient should be counseled regarding what will happen there in SASEP. So in SASEP, the SASEP members will review this patient, and also it should be ensured that adherence is good for at least for 6 months. SASEP members will review this patient, and if they feel that this is immunological failure, patient is having good adherence, they'll advise viral load testing. Patient goes back home. Now, after this one visit to SASEP, patient now will not go back to SASEP anytime. So this is the change. Now, and what will happen is, once the viral load report comes back, then that will be reviewed again by the SASEP, and in absentia, that is, patient will not be present, and whatever the recommendations of SASEP are, that will be communicated to the ART center. For example, they suppose decided now that CD4 is more than 1000, this is immunological, this is first line ART failure, this is the regimen you have to start to your patient, and that communication will go to the parent ART center, and the medical officer there will start the second line ART. For CST focal person like joint director or RC in the state, they should ensure that drugs for at least 2 to 3 patients, second line drugs for 2 to 3 patients at least, are available at each facility. And once the patient is initiated on second line ART, after 6 months, that patient need to undergo viral load, just to see whether there is viral load suppression or not. Otherwise, there is a routine follow-up of the patient is done at second line at the parent ART center. All the recording and reporting tool to be filled as per requirement. I'm just skipping these slides because you all know that this has to be followed. Now, this is the formulation which we use in second line, that is atazanavir-ritonavir combination or lopinavir-ritonavir combination. This is supported by at least one new unused NRTIs, that is zidovudine or tenofovir. We discussed this at length, that why this in place of this. Then continued lamivudine administration that ensures the reduced viral fitness. This also we try to discuss. I hope that is clear now. For repeat viral load, SASEP sends reminders, or we should actively send patients. I will suggest that you confirm availability of kits before you send patients to SASEP, but it is better to send a referral, because if they don't have kits, they will tell you that we don't have. But if you see the guidelines, it is that after 6 months you need to do a repeat viral load testing, just to see whether patient's viral load has suppressed or not. Now, what about the third line ART guidelines? Similar to the monitoring of patients of first line, patients on second line also will be monitored, and same criteria will be seen. If plasma viral load is more than 1000 or latest CD4 count is now this becomes baseline, like immunological failure monitoring. Below pre-second line treatment value, if CD4 falls below pre-second line CD4 value, or if CD4 falls 50% fall from on second line treatment peak value, or CD4 support is not rising above below 100 for 2 consecutive occasions after 6 months, then it is to be labeled as failure to second line treatment, and then those patients are subjected for viral load testing through SASEP of COE. Now for second line failure, these patients are to be referred to COE and not to ART plus, because ART plus do not have third line drugs. Only COEs are in position to start third line ART. In that, again, same process will be followed. Viral load will be done. If viral load is on more than 1000, then for initial months, the treatment will be given by COE themselves. Again, the same thing will be followed. That patient is repeated, will visit the SASEP only once, and then next further decisions will be taken in absentia. But for initial 3 months, patient will be started on third line ART by the COE and will be continued by COE. And after 3 months, if the patient is stable, patients will be sent to the ART plus center of the region, from where the patient will continue on the third line ART. The regimen which we use in the third line ART is Raltegravir, that is 400 mg, Darunavir, that is 600 mg, plus Ritonavir, 100 mg, 1 tablet each, twice daily. There is again something called as NASEP, that is National AIDS Clinical Expert Panel. Any SASEP can refer patients to NASEP in following scenarios like complicated cases, patients referred from private multi-NRTI exposed cases, any intolerance to third line drugs, cases requiring these drugs as alternate second line, any other case as required by SASEP. So I think we have finished with this first part. And one last thing regarding failure. Which is again not as a part of program I'm saying, but there is something called as salvage therapy. Salvage therapy is something, suppose there is a person who has been given almost all ART medicines which you have, and patient is experienced last 8 to 10 years, 12 years, is on ART and is being exposed to every drug and has all those mutations accumulated. So for treatment of such patients, the therapy which is initiated is called as salvage therapy. So there are again will be very limited options available for such kinds of patients. Phenotype testing is may be helpful in these, right? Because you do genotype, every gene is present, every mutation is present. So genotype will not help. Phenotype may be helpful because there you will see what amount of drug or which drug will be helpful in reducing the viral load to at least required concentration, required levels. Then regimens are complicated. Sometimes again, the hierarchy in which the salvage therapy or ARV is given is based on like ARV belonging to the previous unused class, belonging to a previously unused drug class or used drug class, on NRTI combination, ARV associated with the previous virological failure. So if one is not available, second is used. In very rare situations, enfuortide or maraviroc or tipronavir, drugs like this which are not otherwise used are used in salvage therapy. Again, this is just to complete the list. We are not using this in national program because we don't have access to this. So let's move on to the second part of the presentation. I'll promise that I'll finish this as soon as I can, because most of you are aware, as you are already working at ART center, you know about drug toxicities. And also, as expected, you might have heard to the lectures of the UW faculty. Just quickly go through a few important toxicities of first line and second line antiretroviral drugs. Everyone knows that zidovudine causes these side effects like headache, nausea, vomiting, bone marrow suppression, anemia are the serious side effects of zidovudine. These are short-term toxicities of zidovudine. Similarly, nevirapine and efavirenz may cause rashes. Efavirenz specifically, nevirapine may cause again Stevens-Johnson syndrome, also in some scenarios efavirenz, but specific toxicity or side effect of efavirenz is drowsiness or confusion or vivid dreams. Sometimes it may lead to suicidal ideations also. Then medium-term toxicities like bone marrow suppression or anemia, hyperpigmentation, lactic acidosis, proximal myelopathy. All these are medium-term toxicities, peripheral neuritis or pancreatitis. Then lipodystrophy are the long-term toxicities. This is a formula we used as a for estimating the or for measuring the creatinine clearance. You can use this formula, or you can also use applications. These days your mobile phones will have many applications to calculate creatinine clearance. Just put the numbers, you need not write anything and calculate, it will immediately give you creatinine clearance. Why it is required? Because we are using tenofovir in the first line. That is a common drug, and in case if a person develops toxicity to tenofovir, one of the main toxicities is renal intolerance or renal insufficiency or nephrotoxicity, and second one is again for bone toxicity. So in terms of renal toxicity, if patient on tenofovir if develops nephrotoxicity, then ideally is we should not be using tenofovir anymore. But in situations where if that option is not available, then we have to use tenofovir in lower doses. So this table will help you in deciding at what level of creatinine clearance what dose should be used. There are some drugs like Abacavir, nevirapine, efavirenz, atazanavir, which don't require dose adjustments, and also lopinavir and especially PIs. But if those patients are on hemodialysis, then recommendations may differ. You can refer to this table. This is again same table that might help us in deciding the dosages of tenofovir if there is renal intolerance. This I wanted to just mention and highlight in this presentation, because other things you know. There is another formulation these days which is becoming very common is especially in Western world is tenofovir alafenamide. Tenofovir alafenamide is similar molecule as tenofovir diproxyl fumarate, which TDF, which we are using now. So, but the TAF or tenofovir alafenamide does not have those toxicities which we have with TDF. So it has similar efficacy to TDF. It does not have renal or bone marrow or bone mineral density toxicities, but patients on TAF or tenofovir alafenamide may have lipid intolerance or lipid abnormalities. It is safe. It can be used in patients even who have mild to moderate renal impairment with creatinine clearance. This one, TAF have adequate activity against hepatitis B virus also, but whether if it can be used as PrEP or pre or post exposure prophylaxis or occupational exposure, that is not clear. But there should not be any reason why this cannot be used, but it has not been clear by now. So remember this drug, that is tenofovir alafenamide, and this is one drug which is exactly similar to tenofovir without renal or bone mineral density complications. So this is considered to be very good drug, and is being commonly used these days in Western world. So we need to monitor patients on who are on first and second line ART for these toxicities, and wherever you see these toxicities, we need to also see whether there are overlapping toxicities along with the other drug, there is any mix scenario or not, and whenever it is required, appropriate substitutions are to be made. We can grade, or we need to grade these toxicities whenever they are mild to moderate or severe, that is grade 1 to 4. And then based on that, if it is mild or grade 1 or grade 2, you need not change ART. Grade 3 you can consider change, but as soon as the toxicity is reduced, you can consider reinitiation also. But in grade 4 toxicity, you should discontinue. You should never patient require hospitalization, and you should never reinitiate patients on the same drug again. Skin rashes, they again range from mild to severe Stevens-Johnson syndrome or toxic epidermal necrolysis. So whenever a patient is on nevirapine, efavirenz, or even lamivudine may cause skin rash. Some of the PIs may also cause. So whenever a patient develops skin rashes, then immediately you need to grade that rash, closely observe if it is progressing, or even if there is any mucosal involvement or mucous membrane involvement. You should immediately stop the drug and then manage that well, because if you allow that to continue, then patient will land up in Stevens-Johnson syndrome, especially when you are using ART along with the other drugs which have potential to cause skin toxicities or skin reactions like cotrimoxazole or any other sulfa drugs. Then you should be careful. You should not start both of them together. You should start with cotrimoxazole first, and after some days you start with nevirapine or efavirenz. But if that is not the option, then you can start them together also. But if any reaction patient develops, then stop cotrimoxazole first and then closely observe, and if it continues to get worsen, you can stop the ART. But if not, then you can conclude that cotrimoxazole was the offending agent, and then you can either consider desensitization of cotrimoxazole, or you can give drugs like dapsone. So these are just examples, pre-treatment, or this is Stevens-Johnson syndrome because of nevirapine, and just we gave fluids and skin and this is actually because this is from Tamram, where we did HIV fellowship. So skin, we gave fluids, skin and mucous membrane care, that is routine care. Electrolyte were maintained. You can see the difference from the previous slide. Efavirenz, as I mentioned, the toxicity or side effects may vary from some mild confusion to again severe confusion, and also sometimes depression and suicidal tendencies. The easy way is counseling. I know it is very difficult sometimes. Typically it starts from 2 to 3 days or first or second dose of efavirenz, and the side effects they may remain for 2 to 6 weeks. So where very close counseling or support is required to these kinds of patients, otherwise they don't take. They would never like to continue on efavirenz. Especially those who are working on some machineries, all should be actually warned regarding these side effects. Other measures which can be taken, as it is to be taken 2 to 3 hours before dinner, and also dinner should be lighter without much fatty meal. So atazanavir is another drug which may cause unconjugated hyperbilirubinemia. This you should remember, that before initiating atazanavir, you should tell this to your patient that your eyes may become yellow after some days, but you need not worry. This is just a side effect of the drug, but it is not harmful. So if patient develops yellowish discoloration of eyes or nail or skin or other parts, then if you do serum bilirubin, then you may see unconjugated hyperbilirubinemia, that is indirect hyperbilirubinemia. If you see that, you need not worry, because this is just a but it is again easy for us to say, but it is difficult for patients to accept, because everyone will be asking that you are having yellow eyes. So they should be agreed with that, but that is one of the problems with atazanavir. But where to stop? There is a formula which you can apply, which is called as child pug scoring system. If any of this is present, then you give certain points to that particular patient. If there is encephalopathy, there is grading of encephalopathy also. In the next slide you can see it. So if there is grade 1 or grade 2, you will give points. Similarly, you will go on giving points to these patients. If points are 5 to 6 points, then you can, it is said as class A child pug score. 7 to 9 is class B, and more than 10 is class C. Atazanavir can only be used in patients with chronic liver disease in child pug class A. It should not be used on second line patients with child pug B or C. If this is the total, then you should not be using atazanavir. So I think we tried to cover many things in this, so I hope it will be useful. For those who already knew, it will be just a revision. For those who want to refer, you can please go back and refer to the recordings of this session. If you have any questions, you can post now, later, or you can post in the group, and also you can post or raise into the forum which is provided on the canvas. So thank you very much, and I'll again request you to please be regular with submission of your assignments. If you miss them, don't worry, you complete the homework assignments and extra credits so that there will be some balance somewhere, though it will not be as a complete replacement, but still the extra credit might help. Can I get the PPT slides? PPTs are already there, sir, in on the canvas. Both the PPTs are there in PDF form, and the NACO PPTs which I have used. Okay, if you want my slides, then I'll share this PPT with you also. Because I have added few slides which I had made, so I'll share that. I'll request Praveen to share presentation of this presentation with the group. I got you. Okay, then thank you very much. We'll again get back in the next week. That is next Saturday, same time we'll have session on pediatric HIV, which will be again very helpful for all of us. So thank you and see you again.